Good evening, sir. So, shall we start the session?
Hi, good evening, Sana. Yeah, we should
Yes,
start the
sir.
session.
So, more
Uh,
students will also be joining us, though. Okay.
how,
So, we'll be
how much
starting.
time should I wait?
Sir, we can start the session. There's no issue.
Okay, very well.
So, good evening, all the aspirants present here. Today's station is Cardiovascular, and the faculty that we have here is Dr. Varun Pushkarna, sir. He is a senior consultant, internal medicine at Fortis Escortis Hospital, Amritsar. And all the aspirant, this is going to be a very interactive session. Do participate. Thank you.
Hi, good evening, participants. Can you see the screen?
Yes, sir.
Yes, great. So basically, I assume everybody of you are ready for your PACES exam, and this is just a brush up for your cardiovascular station. So it's basically the mindset that you walk into the examination with. See, they are not wanting you to be a cardiologist. They're not wanting you to join as a consultant in cardiology. They just want to check you how safe a doctor you are. If you get a patient of cough, breathlessness, chest pain, swelling of the feet, palpitations, blackouts, that you are able to assess those patients on their cardiovascular needs or not, and will you be able to identify the signs which are present, and you are able to identify the signs which are not present. I mean, you are unidentifying those, that these things are not present, so this diagnosis is ruled out. So they just need a very, very thorough and a basic understanding of cardiovascular sciences from you, and that is how you should go into the examination. So in this station, we all know we have 6 minutes to examine and 4 minutes to speak about what we have examined. Now, these examiners have made these line. Each line has a meaning. Please read them carefully and very thoroughly. These examiners, they are not just looking at your ability to hear a click or a rub because you're auscultating, but they'll be observing your scheme of evaluating the patient, your mannerisms, how you proceed, from where you proceed, have you rehearsed the technique well, are you adept to any new situation that can turn up immediately at the bedside. So they are just looking for your rhythm and your diagnosis synthesis, how you process the information that has been given to you. We will come to certain exams. In these 30 minutes, we will cover the dance of the paces. Dance means the rehearsal, the repetition, the expertise that you should achieve by doing it again and again. This is called the dance of paces. I mean, this is my own way of expressing, but you can do this dance again and again in all the different systems, not only just cardiovascular, neurology, respiratory, gastroenterology. I mean, every system there is a scheme of assessing and evaluating the patient, not only for the examination, but also for your routine assessment of any patient that walks into your room, so that you don't miss out on any finding. You will be surprised to know that recently a patient came to my OPD, and the patient's chief complaint was persistent epigastric fullness and pain. Pain was dull and has been present for 4 years. Imagine the patient had gone to four different gastroenterologists and had been done 3 times endoscopy upper GI, and nobody actually put the hand on the patient's abdomen. None of the four gastroenterologists examined the patient themselves. Can you imagine what I found? Any guesses? Now this is a cardiovascular station, but I'm just pressing upon the importance of feeling the patient. Can you just make a wild guess what when I was examining what I found? Any wild guess? The patient had been 3 times endoscopy done. Every time H. pylori came positive. Every time he was given treatment for whatever days of H. pylori. When I palpated the abdomen, there was a epigastric mass. Now there is a law which says if you feel in gallbladder, or if you are feeling a mass in the epigastrium, where is the mass located? It is located in the retroperitoneum. So in the OPD itself, I ordered an ultrasonography abdomen, which was not ordered by four gastroenterologists. I ordered a CA 19-9 in the first interaction with the patient. And you would be surprised that CA 99 came out to be 638. Ultrasonography did not see anything because of a gaseous abdomen. Just because CA 99 was positive, I got a CT abdomen done, triple phase, and it diagnosed the patient to have a tail and body of the pancreas carcinoma. Thank God no lymph nodes were involved. I have got that patient operated. The surgery has been done. He required a splenectomy along with. But this is the importance of feeling the patient. For 4 years, the patient has been moving about. Nobody kept their hand on the abdomen of the patient. This is important. This is important that you do not miss the dance steps, the steps of the dance. You have to complete that dance. You have to remember this. And then there are big four pathologies of cardiovascular system that I'll be sharing with you. And how to close the deal. You have examined, you have found something, you have maybe not found anything, but you have to close the deal with the examiner. You have to go home. They also have to go home. So, number one, efficiency. Your practice should be so meticulous that you seem efficient. If you fumble with your stethoscopy or percussion or palpation or anything, you lose the time. You are not going to auscultate the back of the lungs or the palpate the liver. Why do we need to palpate the liver in a cardiovascular system? Anyone?
Right heart failure causing hepatomegaly.
Okay. Right heart failure causing hepatomegaly. Another thing, pulsatile liver. Pulsatile liver is seen in severe TR. Then hepatojugular reflux. Hepatojugular reflux is when you are suspecting that the patient, because these patients who come to you in PACES cardiovascular station, they are going to be treated patients. They should not be in heart failure, active heart failure. So if they're treated patient, they'll be on diuretics. So there are chances that the JVP would be entirely normal. Only when you press on the liver, mind you, before pressing on the liver, you have to ask the patient, do you have any pain in the abdomen? If they do not have any pain in the abdomen, go ahead for checking the hepatojugular reflux. Press it there firmly for say 10 seconds. See the changes in the JVP. If the JVP rises on compression on the abdomen, on the right hypochondrium, that is the time when then the examiner will be impressed that this doctor has an insight that this patient could have heart failure. So I'm examining this patient properly. So follow this sequence. Start from the foot end of the bed. Look at the foot end. Just examine. Don't touch anything. Just observe. See if the patient is breathless. See on the face of the patient if there is any malar flush or any visible pulsations in the neck or on the forehead. Then, after standing at the foot end, move to the hand of the patient. Cardiovascular system examination starts with the hand, ends with the feet. So before leaving the patient, touch their feet, take their blessings. You will find many things. So check the hands for clubbing so that you can differentiate between a cyanotic heart disease and a non-cyanotic heart disease. Look for splinter hemorrhages in under the nails, marker of infective endocarditis. Look for them. And then once you have checked the fingers, checked for the splinter hemorrhages, then you check for any Dupuytren contracture in the palm, shake the hands with the patient, and while shaking, move to the radial artery palpation. So once you check the pulse, Immediately, while you are checking the right radial pulse, check the left radial pulse also with the other hand, so that you can check for radial delay. Then go to the elbow of the patient. In elbow of the patient, feel for the brachial artery. Once you feel for the brachial artery, go for checking the water hammer pulse. So while checking the water hammer pulse, curl your right hand around the radial artery of the patient, that is wrist of the patient, and press your left hand fingers on the brachial artery, and then lift the arm after asking the patient, do you have any pain in the shoulder or in your elbow? Because I'm going to lift it up. Just let me know. If you have any pain, then I may not do it. He will say, I am okay. Then check for the water hammer pulse. Once you have checked for this uh, elbow, you go up the arm to the shoulder to the neck. In the neck, what do you see? The JVP. JVP is the most failed part of the exam. If your patient is sitting, tell him to lie down with a 45-60 degree angle. If he is lying down flat, move the head end up and make him sit in that angle. And then bend your knees a little to come at the level of the JVP to check that JVP. If the JVP is high, try to make a face as if you are trying to look for the CV waves of tricuspid regurgitation. Then, once you have checked the neck, go to the lips, see cyanosis, check the tongue, check the cyanosis, and look for any high arched palate. It could be a Marfan syndrome. Look for any conjunctival. Then from the lips, you go up to the eyes, check the conjunctival pallor, check for xanthelasma in the upper eyelid. Then you come down from the face on the chest, where you start with the palpation. Do not put your stethoscope directly on the apex beat. How do you know where the apex beat is? If the patient is having dextrocardia, you are going to place the stethoscope on the left side of the body, of the chest, and you have failed the exam. Congratulations. You must place your hand on the chest under the left side nipple, left intercostal, fourth intercostal space. Feel for the apex beat. If you're not able to feel the apex beat, tell the patient to turn to the left side. And once you have felt the apex beat, only then go for putting the stethoscope at the point where you felt the apex beat. Otherwise, if you do not feel on the right side, the the doctor will be impressed that this man is not going to put the stethoscope on the patient until he has found the apex beat. And sometimes in obese patients, female patients, you are unable to find, but at least you demonstrate that I could not find it on the left side, so I checked it on the right side. The examiner may ask you also after the examination, why did you palpate the right side of the patient? Tell them, I could not feel the apex beat on the left side, so I checked it on the right side. There is nothing wrong in it. In fact, it is the method, it is the way, it is the thing that is expected out of you. If you have felt the apex beat, then check if it is displaced or if it is heaving type, if it is tapping type. So first with your palm, then do all the hand movements that are required, like putting the side of the ulnar border of the hand around, and checking for the heaves and tapping, and also for the thrills. Thrills are felt with the palm of the hand. Do that. Show them that you know this and you have actually rehearsed this. So do the palpation properly. Once you have palpated where the apex beat is, the next is a cakewalk. Put the stethoscope where did you feel the apex beat. Start from the apex beat. Use the bell for the apex. Start from the apex, and then just the and once you have auscultated the apex with the diaphragm, move the stethoscope to the bell side. Auscultate for any rumbling murmur. Okay, diastolic rumble, and then diaphragm for all the four places. Always time the murmur with the carotid pulse. Some students are looking for brachial pulse, radial pulse. No, put the stethoscope. If you are right-handed, put the stethoscope on the mitral area. If you have located the murmur, move your left hand to the right carotid of the patient. Feel it. Tell the patient that I'm going to press my hand on your neck while I'm auscultating your chest. So do these two things together so that the examiner feels that you understand that you have found a murmur. Now you are timing the murmur. If you have not found a murmur, do not put your hand on the carotid. Remember, some people have the habit of putting the stethoscope and carotid fingers at the same time. Man, you haven't found the murmur. Why are you timing anything? If you have the murmur only, then time it, na. So once you've done the auscultation, these are the four places where you should be auscultating. Aorta is in the diagram in the life, it is on the left side of the heart, but the aortic aorta's location is basically on the right side, right second intercostal. So that is the aortic area. So this is the aortic area. This is the pulmonary area, exactly on the left side, second intercostal. This is mitral, and just next to the mitral. So only one place is there where you have to place the stethoscope for on the right side of the chest is to auscultate for the aortic valve. Everything else on the left side. Okay. So now the big four pathologies. You are 90% likely to see one of these four. Now they have a package that comes with them. Remember, they will not keep a case which does not have findings. They may, if they have not have found any case, they may keep entirely normal cardiovascular patient, but that is a rare thing. You will have a patient who will have findings. Okay. So don't say that I could not find anything. There will be something. If you have double checked, only then say that I could not find. Aortic stenosis, very important, very common. Slow rising pulse. The pulse will be very slow. The patient may be on beta blockers. The heart rate will be slow. It's a slow rising pulse, very slow rising pulse. Narrow pulse pressure. You may not have a blood pressure equipment there, but you should remember that I'll tell you what to do if they do not have a blood pressure there. You can ask the examiner while examining, sir, may I ask what is the blood pressure of the patient? If you do not see any blood pressure equipment anywhere, if you do find one and you are measuring, it is the best thing. If you are measuring and they tell you do you don't need it, then don't do it. Don't don't outsmart them, just be smart enough. Okay, so there will be slow rising pulse, narrow pulse pressure, and a harsh ejection systolic murmur that is radiating to the carotids. So the murmur will be on the right side. So you should move to the right carotid first and left carotid later. And tell the patient to hold their breath while you are auscultating the carotid. These are little things that make you look like a detective who's trying actively and hard to find the actual signs. And in a patient of aortic stenosis, it is very important to auscultate the bases of the lungs. Why? Because any evidence of heart failure, presence of creps in the bases of the lungs is a direct indicator that the stenosis is critical. This patient needs surgery or aortic valve replacement or balloon aortic valvotomy. The next important case is mitral regurgitation. Very important. The findings will be a displaced hyperdynamic apex beat. How do you identify apex beat? Palpation on the left side of the body. And a pan-systolic murmur at the apex radiating to axilla. So if you have found a murmur in the uh, apex area, first thing is place your right hand index finger and middle finger and the ring fingers, all three together at the right carotid. And once you have timed the murmur, move to the left axilla, auscultate. If the murmur is radiating there, it is MR, mitral regurgitation. Common context is that the patient will have a click, mind click, and they will place only those patients who have a very profound click that you can auscultate easily. Always think of mitral valve prolapse. If they have a regularly irregular pulse, tell them that there is a murmur in the mitral area and the pulse is irregular. This patient could be rheumatic heart disease having some mitral valve pathology. I'm not clear about the pathology. If you are not able to auscultate the murmur properly, tell them There is some mitral pathology, there is atrial fibrillation. I think this patient may have rheumatic heart disease. This is a smart way of telling them. Then aortic regurgitation, collapsing pulse, check the water hammer, wide pulse pressure, again the importance of checking blood pressure, BP of 160 by 60, and an early diastolic murmur heard best at the left sternal edge, patient leaning forward in expiration. So if you have auscultated a murmur, a systolic murmur or a diastolic murmur, tell the patient to bend a little forward. This will help you, because in that short period of time, putting stethoscope on mitral area, you are putting your fingers also on the carotid. Sometimes you're unable to time the murmur, you're unable to say whether it is a systolic murmur or a diastolic murmur. Then just moving the patient to sit forward will make one murmur go away. The mitral murmur will go away, the aortic murmur will persist, and then you can say it is aortic regurgitation. So, and the examiner will also feel that you are knowing what you are doing. Mention Quincke sign, Demisset sign. The signs are there, throbbing uh, artery on the forehead. Only mention if they are present. If you don't, just don't. If they ask, fine, what are the other signs of aortic regurgitation? Tell them that I'll make the patient sit with legs suspended and I'll see if the legs are bobbing, the head bobbing sign. Now, these things are, out of your knowledge. You have to tell them. You don't have to actually, you look for them. If you don't find them, that doesn't mean that, you don't have to tell them. If they ask you, tell them. Don't say otherwise. Mitral stenosis, tapping apex beat. Oh my God, you cannot miss a patient of tapping apex beat if you have ever felt that. A tapping like somebody is knocking from inside. They want the door to be open. Tuck, tuck, tuck. So that is the feeling. Palpable S1, Meller flush, mid diastolic grumbling murmur heard with the bell of the stethoscope in the mitral area. You must ask the patient to roll on to the left side to listen with the bell in the expiration. Tell the patient to breathe deep outside, exhale. Only while exhaling, tell them. Examiner is very intelligent. You put the stethoscope's bell on the chest, put it lightly when the patient is breathing in, put it, press it firmly when the patient is breathing out, because they will understand that you are trying to look for a mitral diastolic rumble, because that is heard best in the expiration. Now, you have checked these four things. Aortic stenosis shares its problems with HOCM, hypertrophic cardiomyopathy, also. So, it is very important that you keep in mind that the murmur of aortic stenosis will radiate to the neck very effectively. Radiating to the neck means radiate to the carotids. But HOCM murmur, sometimes it doesn't. But you definitely will auscultate a murmur on the right second intercostal space. It's a systolic ejection murmur. And there will be two or three apex beats sometimes in HOCM, because the heart beats many times. There are variable apex beats in HOCM. So when the examiner says, tell me your findings, you do not give him a list of things to shop from market. No, just give them a diagnosis with positive findings. Say that on examination of this patient's cardiovascular system, because you were entitled to examine the cardiovascular system only. On examination of this patient's cardiovascular system, my main finding is a murmur, a systolic murmur in the mitral area radiating to the axilla. I also note that this patient has atrial fibrillation, irregular pulse, indicating atrial fibrillation. I think the patient is currently in a compensated state of heart failure, because there are only few crepts in the basis of the lungs. So my diagnosis is probable rheumatic heart disease with mitral regurgitation, with atrial fibrillation, with a compensated heart failure. Now, for example, if the patient has aortic stenosis, you say, I believe or I feel that this patient has aortic stenosis, or if you're not sure about aortic stenosis or HOCM, say that I feel this patient has a LVOT. LVOT is left ventricular outflow tract. Say that I feel there is left ventricular outflow tract obstruction, which could be caused by either aortic stenosis or HOCM. There is a grade, the murmur, for example, 3 to by 6 ejection systolic murmur that is radiating to the carotids, and it is associated with a slow rising pulse. I would love to check the blood pressure of this patient. I could not check because of the want of time. But I would love to check the blood pressure of this patient. They would ask you why. What do you want to see? Tell them I want to see if there is a narrow blood pressure, narrow pulse pressure. The apex beat should not be displaced. The lungs are clear, suggesting that this patient is currently compensated. So I feel this patient has aortic stenosis. And remember, there are so many things to look for. These are the pearls of the PACES. I love these findings because students see them and miss them and don't speak about them. There was this lecture I was taking on a hepatobiliary case. The patient had large subcostal incision, literally, from one end of the abdomen to the other, just under the ribs. The patient had a liver transplant, a large incision. The students saw the incision, but they didn't know how the liver transplant incision looks like. So please do it, Google it. If you have not seen a patient, check for it. Who are the patients? How does the incision scar of pancreatectomy or liver transplant looks like? So that once you see those patients in examination, you know exactly how they look like. The scars in cardiovascular system can be midline sternotomy scar. It can be a midline sternotomy scar, or it can be a mid-cab here. Fourth intercostal on the right side, fourth intercostal on the left side. Look for the marks of chest tubes. Okay, these are small, small. If the patient has had a CABG, ever, CABG is coronary artery bypass grafting. So look for a pacemaker incision here at the subclavicular space. Here you will find a mark. You might even palpate a pacemaker underneath. Always look for a midline stenotomy, maybe a valvular replacement or a CABG or a subclavicular scar for a pacemaker or an ICD placement. If you see a scar, hear a click, it is a prosthetic valve. Now, whether it is a bioprosthetic or a metallic valve, this is the examiner will ask you this question. So be prepared. Be prepared. Okay. The lungs, never finish a cardiovascular examination without auscultating the lungs. So when you are scheming up for cardiovascular system, I just stopped, at auscultation, but then you need to go on the back of the patient, auscultate the bases of the lungs, and then look for sacral edema, and then finish your examination by looking for any pitting edema in the ankles. That completes your diagnosis. And if you are very smart, then look for femoral. I mean, these patients may not allow you to feel their femoral pulses. So ask them, are you comfortable if I put my fingers in your thighs or your groin to feel for your pulses? They'll say no. No means a no. Don't do it. Then feel for the dorsalis pedis artery. Do feel. Examiners are impressed by these little things. Feel for the dorsalis pedis. You should know where dorsalis pedis is. If you have not found the dorsalis, look for the posterior tibial. If you not found posterior tibial, limb feels cold, go for the popliteal artery. These are the ways to impress the examiners, because the eyes will try to see what the mind knows. So train your mind, train your eyes again and again. So never finish a cardiovascular exam without listening to the lung basis for any pulmonary edema, and check the ankles for pitting edema. Confidence comes from repetition. do the steps of the dance again and again until you don't have to think about where your hands go next. If you stop or pause, this shows lack of confidence, lack of practice, and it creates a negative impression in the minds of the examiner. Is the lecture clear to you? Yes?
Yes, sir.
Any questions till now?
Yes, sir. When they ask to present the case, shouldn't we start from the initial findings? Like, I did not find there was no sign of endocarditis, and the pulse rate was this, and it was irregular.
See,
And
this only tells them that you are a trainee under training. But you want to manifest that you are very confident. You don't have to manifest that you are underconfident. You first tell them that you have to be seen as a person who is inquisitive, who has done and labored hard and try to find the findings. So when you have found the findings, let us say you went into a mine to look for diamond. It is a coal mine. If you come out of the cave, you are coming like excited. What have you found? Coal could have been found by everyone. What different have you found? Would you tell them that I found this thing? This looks different from it. It is a diamond properly, probably. So when you have ventured into a patient's cardiovascular system and you have found the signs, you should start with telling them this is what I have found. It is their job to see that you did not mention you did not find. There are hundreds of signs which you will never find in a cardiovascular system. And mind you, you just have 4 minutes. So you tell them your diagnosis so that they can start with the viva. You tell them with your positive findings. Negative findings only if they ask, don't you think this is this? Then tell them, I auscultated, I could not find this. I
okay, sir.
palpated, I could not find this. This patient is in sinus rhythm. This patient does not have an atrial fibrillation. You tell
Okay, sir.
them. So this will tell them that this person knows the subject. He knows, you know, he has not seen this patient to impress us. He has seen the patient to see the patient. He has seen the patient to make his own satisfaction, that yeah, now I'm satisfied with the examination. I'm ready for the diagnosis. Okay.
Thank you, sir.
So examine every friend that you have, your parents, your cousins, your brothers, sisters, your servants, anyone you find, examine their cardiovascular system every day, 3 4 times. Let them get irritated with you, but they will be normal. And then once you see a patient who has a finding, you will say, hip hip hooray, I have found something. You would want to tell everyone that there is a murmur there, and that murmur is radiating that side. It is radiating to carotids, it's radiating to axilla. It increases if I tell the patient to bend forwards. Your excitement will be visible on your face. That is what the examiner wants to see. That's all. Okay. Any other question? Shall we move forward? Okay. How would you complete your examination? This is examiner's questions. Now I'm preparing for the questions that examiners, if I am an examiner, I will ask the patient once they have completed their examination. I will always ask the student, how would you complete your examination? Then what I expect is, I let you know. I expect that you would say, I would like to check the blood pressure to look for any narrow or wide pulse pressure. Then I would want to perform a fundoscopy to look for Roth spots or hypertensive changes in this patient. I would like to perform a urinalysis to look for any microscopic hematuria in infective endocarditis. Or I would love to examine this patient's peripheral vascular system If you did not feel for the dorsalis pedis posterior tibial popliteal artery, or in one of in my exam, one of the patients had an amputated right leg. So I told the examiner that I would like to feel for the pulses in the left leg also. So he said, go ahead. Because this is so important. Why was the leg amputated? You cannot ask questions in an examination setting of PACES. You just have to examine, that's it. So you ask the examiner, I want this patient's left leg exposed because the patient was wearing a socks. And that would have taken time for me to remove the socks and palpate for the arteries. So when I asked the examiner, I want to examine the left leg, he said, go ahead. That he also understood that I will need an extra time to examine that. So they understand that fine, this man knows the job. So look for any ulcers on the feet, digital ulcers. And of course, looking at the feet, there might be digital gangrenes. Okay. I would ask, what are the three most important investigations you would order? This is after you have presented the case that I feel this patient has this. Be very specific and hierarchical. Tell them I need an ECG. I think the patient has an irregular rhythm. I feel that this patient has atrial fibrillation, but I would like to prove it on an ECG because atrial fibrillation is a ECG diagnosis and it will help me identify mitral disease as the source of atrial fibrillation. Or I would like to check for LV hypertrophy in this patient because this patient I feel has aortic stenosis. Might be I'll be able to find left ventricular hypertrophy in this case. Then never forget saying a chest X-ray. People just think chest X-ray is a respiratory examination investigation. No, tell them that I need to get an X-ray done for checking for cardiomegaly or any pulmonary edema or for curly B lines or for fluid in the right lung fissure. Then tell them echocardiography. This is the gold standard to quantify the and severity of any valvular lesion and ejection fraction. So it is very effective. Then there are certain pathophysiological questions that examiners love to ask because they test your deeper understanding of the case that you just presented. If you have said that this is aortic stenosis, any genuine questioner, any genuine examiner would ask you, okay, this is aortic stenosis, fine. How would you determine the severity of this aortic stenosis clinically? You don't have an echocardiography with you. You have to tell them. These are the four signs. One is the slow rising pulse, parvus et tardus. Second is a narrow pulse pressure. Third is an absent S2, that you auscultated. The stenosis is so bad, this patient does not have any closure of the aortic valve. It's already so closed. Then presence of S4 or presence of crepes in the lungs, basal crepitations, or pedal edema or hepatojugular reflux. These are the findings that you will tell that, okay, I will see these signs, the pulse pressure, absence of S2 or soft S2, and presence of heart failure signs. If they are present, it is a critical or a severe aortic stenosis. Then the next question will come. So, what will you tell the patient? How are you going to treat this patient? Medically, surgically, transcutaneously. Nowadays, we have a lot of options. They will ask you what are the indications for valve replacement and aortic stenosis. Remember the mnemonic SAD, aorta is sad. Syncope, angina, and dyspnea. Even if the ejection fraction is normal, but if the patient is asymptomatic and the ejection fraction has decreased, then that's another indication for valve replacement. So, a sad normal heart, that is syncope, angina, dyspnea, with Normal ejection fraction are the patients indicated for aortic valve replacement because they're symptomatic. Some patients are not symptomatic, but ejection fraction has dropped. Now, these patients also need aortic valve replacement. Now that you've mentioned that this patient has a scar in the chest, there's a midline sternotomy scar, and blah, blah, blah. So, this patient has a prosthetic valve. So, how can you tell if it is a metallic or a bioprosthetic? This is lovely first class question that everybody will ask. So metallic, you will hear a loud, crisp metallic closing click. So you tell them that I auscultated. There is a mitral. There is a click, metallic click in the mitral area. There's a metallic click in the aortic area. I think there is a metallic valve, and there are signs of anticoagulation. The patient has some ecchymosis. I feel the patient is on warfarin or vitamin K antagonists. Bioprosthetic valves, they sound very similar to normal heart sounds. They do not have the click. They're common in the elderly patients, and there is no significant anticoagulation or their markers. So it's very difficult to find for bioprosthetic valve. And you can just say that this patient has had some surgery for which sternotomy was done. It could be a bioprosthetic valve because in those patients there will be no features, there will be no murmurs. Maybe there's a flow murmur, but that is not significant. So you may not find anything in a patient who has had a valve surgery and a bioprosthetic valve. All you have to look for is a sternotomy scar. That's it. Now comes the worst case. I had a case in my PACES exam that had aortic stenosis and a pulmonary stenosis both together in the same patient. So the examiner kept on asking me, "Is there anything else that is present in this patient?" So I could auscultate. I couldn't auscultate, but there was definitely a tap. The pulmonary uh, area, there was a heave, and so I actually knew there is something wrong with the pulmonary area also. So when the examiner, she was a lady from King's College London, she was a great examiner. So when she asked me, she brought me to that level. She said, "Is there anything else? Is there anything else that we've been missing here?" So I said, "Yeah, there is something in the pulmonary area, but I'm not entirely sure because the aortic stenosis was so loud in that patient." I said, "A2 is so loud that I cannot make out the P2, but P2 is not fine because there is a right ventricular parasternal heave." She said, "Fine, this patient has a pulmonary stenosis." She only told me, she only gave me the diagnosis. So, this is how you should be looking at the lesions. If you hear an apical diastolic rumble and a pansystolic murmur, this is mitral regurgitation with mitral stenosis together. This is classic for rheumatic heart disease, very difficult to find in these days. But still, because it's a textbook case, you might have a chance to see such a patient in the PACES. And the last tip, the I don't know strategy. See, don't say I don't know. Many students are very comfortable about saying I don't know. But if you are asked a question like I was asked, "Is there anything else? Is there anything else?" Teachers love to ask these questions. Don't say I don't know. Twist it. Turn it into a brief summary. Be honest, but be clinical. Say, "I'm not entirely sure, but in this patient with this presentation, there should be this, but I haven't found this. So I would like to get an echocardiogram or an ECG to precisely seek, because sometimes the patient is in complete heart block. Sometimes the patient is in second degree heart block, or generally sinus bradycardia. You may not ever. Sometimes patient has atrial flutter. In atrial flutter, you can only feel the P's that are conducted and they are fixed. Atrial flutter with a fixed conduction. So you will actually feel for bradycardia. You will feel that the heart rate is 60, but the patient will be having palpitations. When you auscultate, you will be auscultating like a train is running in the heart. But when you feel for the pulses will be very less and they will be regular. So tell them, I'm not entirely sure, but I would like to get an ECG because the heart rate is different from the pulse rate. Pulse rate is pretty regular, so I think this patient may have an atrial flutter with a fixed AV nodal block. So these things, they bring out the maturity in you, that you didn't say that I don't know. You just said, fine, if there is something, I wasn't able to find that. Tell them, be honest, and present in a manner which where you seem to be logical, methodical, and mature. That is all. If there is any question from your side, feel free to ask. Now is the time. Having questions is a good thing.
Sir, can you please explain us about double valve recognition, double valve replacement recognition?
See, valvular replacements would only have a sternotomy scar. If the patient has had now double valve replacements would be either aortic and mitral or mitral and tricuspid. Fine. So if the patient is a young patient, they would definitely have a mechanical valve. Okay. So metallic valve, mechanical valve. When you auscultate all the areas, then you'll be able to identify that there is a click here in the second intercostal space on the right side. It is aortic, and it is very difficult to differentiate between mitral and tricuspid because the areas are so close. But definitely, if you see auscultate a click, a patient has in the mitral area, even if it is a tricuspid valve replacement, you can safely say there is a murmur, because even if it is a tricuspid valve, a metallic valve, you will always auscultate on the mitral area and you will hear the sounds as loud as in the tricuspid area. So double valve replacements, if the patient already has a valve replacement, it is honestly very difficult to differentiate if the patient has two valves, because there will be only one sternotomy scar, and having one sternotomy scar means the patient has had a cardiac surgery. So you can safely tell them that this patient has a, they will never ask you that, okay, this patient, so is this a single valve or a double valve case? No, they will not ask you. But if you are lucky enough, you will have a mitral and an aortic. The mitral and an aortic are, because there are two different places where you auscultate, you can safely say that this patient has a DVR, that is double valve replacement. One of them seems to be aortic because there is a click in the aorta area, and then there is a click in the mitral area. So these are metallic valves. So they will NR management, drugs that are involved, drugs which cannot be given, drugs should be given, done of anticoagulation and prophylaxis. So that will be the viva. But honestly, differentiating between tricuspid and mitral is very impossible. Differentiating between aortic and tricuspid or aortic and mitral is easy, and you can also diagnose it by easily by auscultation. You just have to follow the scheme, and you should have to believe in yourself that what I'm auscultating is actually there. Okay, sir. Okay, task for you. Uh, but remember, cardiac patients will be textbook patients. If they were unlucky, they could not find one patient, they will have a normal cardiovascular system examination. It is not a trick, but it is sometimes, they need to conduct an exam, so they would keep any other patient who will not have any findings. So that is a rare thing, but still it can be there. So prepare well, learn your steps, very well. Keep doing them again and again. Keep practicing, and the more practice you do, sharper you get. Thank you very much. Okay, bye, bye, students. Bye, Sana.
Thank you, sir. And thank you all the aspirants for joining. Our next session will be on January. Thank you, sir.
Thank you.